We have 4 amazing speakers, 4 excellent lectures about the different aspects of hepatocellular carcinoma. Hepatocellular carcinoma is one of the commonest malignancies worldwide, and it's a big health burden in our community. Our first lecturer of the day, I would like to welcome Dr. Ghassan Abu Alfa. He's an associate professor in Memorial Sloan Kettering Medical Center. He's a well-known and recognized international speaker in the oncology and hepatobiliary communities. Dr. Abu Alfa did his medical school training in the American University in Beirut, then went on did his postgraduate training in Yale University Medical School. He's a very well-established researcher in the field of oncology with special interest in hepatocellular carcinoma. He has multiple high-impact publications in prestigious journals such as JAMA and The Lancet, including a landmark randomized trial about doxorubicin versus doxorubicin sorafenib for patient with hepatocellular carcinoma. Dr. Abu Alfa currently is the Vice Chair of the National Cancer Institute Task Force for Hepatobiliary Cancers. With all further ado, I would like you all to welcome Dr. Abu Alfa to the podium. It's all yours. Thank you.
Good morning. Thank you very much for the invitation, and especially thanks to Dean Lahwal, and congratulations on your conference. And my apology that I will be heading out after my lecture, so please, if any questions, I would love to answer them before I leave back to New York. I just arrived yesterday. And definitely I will try to hopefully make that introduction for the other speakers to continue on the same subject as it was already introduced. And without any further ado, it's a specialized cancer conference, so no need for me to go through the details of introduction for HCC, but I'll jump on right away into the, do I need to, do I have to tell you next, or how do I move the slides? No, it's not working.
Can we get audio visual, please, to the podium?
Okay, maybe the IT person will have it. Thanks. Moving the slides, open them. It's not working. I will move to. Okay, sounds good. Okay, so I'll jump on right away to 5 subjects I would like to touch on today. The anti-angiogenic ceiling, it's a concept that I introduced at the World GI Congress in Barcelona last June. How to overcome it, does it really exist, filling the gaps, and custom-made therapy. So in regard to the anti-angiogenic concept, exactly as we heard in the introduction, the sorafenib was the first drug to be looked into in the new era of HCC. And we were honored to do the first clinical study with that. It's a phase 2 trial. And also, as I said, if we knew at that time, we went ahead and did a phase 2 looking at response rate, thinking that those tumors are going to shrink, and we included patients with Charles score A or B, thinking that the drug is probably safe, and we thought that this would be enough to register the drug based on some good results if they were to happen. With this said, the trial was negative. Actually, the response rate was only 2.2%. Even nowadays, for an oncologist, 2% response rate is not exciting anymore. On the other hand, 1/3 of the patient had stable disease, and that stability of disease was commensurate with an improvement in median time to progression to 4.2 months and median overall survival of 9.2 months. And to give an idea for those in the field, using nothing or doxorubicin or any other therapy you wish, probably the median survival will be about 6 months. So clearly there was some signal over here that despite that the primary endpoint of response was not met, nonetheless we felt like there could be some action that sorafenib is imposing on the disease, but not necessarily that we're able to understand it by response rate. With this said, one of the observations that we were the first to report is that tumors actually don't shrink, but they necrose. And as you can see over here, this is a patient that was operated on at Sloan Kettering by human fund, and unfortunately occurred. As you can see, there's in the center of the slide a deposit in the peritoneum that's biopsy proven HCC. And this patient was offered actually to be on that trial. And after 2 months, which is follow-up 1, you can see to your sharp eye that the tumor remained the same as size, probably a little bit bigger even, but inside definitely a change in consistency. This was the first description of that possible necrosis. And I give a lot of credit here for Larry Schwartz, who is the chairman of radiology at Columbia now. Between Larry and myself, we were able to develop a computer program that actually will measure the volume of those tumors, but at the same time we look at how much necrosis you have. And as you can see, the volume did really indeed grow or increase, while the percent necrosis jumped from 2% to 53%, and even it persisted. Along with that, our aim was to really understand if this will correlate with survival, because you can't do any marker in oncology without really correlating it with the ultimate outcome, which is survival. And I have to say, so far we were not successful. As you can see, survival against tumor necrosis over volume ratio. And why do we do a ratio? Because we want to correct for that growth. So we try to divide by the volume. The p-value is only 0.89, so clearly no correlation. The good news is this is actually currently still being looked at. We have a U1 grant from the government, actually $5 million worth, that will look prospectively, part of the national trial, which I'll introduce in a second, into that correlation between tumor necrosis and volume. So something that's still in the works. With those two kind of findings, this led to the phase 3 SHARP trial that you are well aware of, that was led by the Barcelona group, that randomized patient to sorafenib versus placebo. And the primary endpoint, of course, was overall survival. That study was positive. It showed a median survival for the sorafenib of 10.7 months, which again is quite exciting, compared to placebo 7.9, clinically and statistically significant. This made sorafenib become approved in the US and worldwide as the standard of care for advanced HCC. So, as you can imagine, when you have data like this, there will be a lot of interest in the disease and in trying to find other therapies. And almost it became a race. As you can see over here, I lined up most of the studies that were done afterwards at the phase 3 level and some at the randomized phase 2 level. And I would like to focus on those which are mainly biologic anti-angiogenics, because the idea was that anti-angiogenic therapy, being a tumor that's vascular, sorafenib already succeeded as an anti-angiogenic therapy, it does make sense to test other, maybe even more potent anti-angiogenic therapies. And if we start at the bottom, Rivneb, as you can see over here in the phase 2 10 month, I just reported literally 2 months ago in Boston at the ASMD 9.5 months for the median survival. Lenifnib in the phase 2 10.4 months. The study in the phase 3 is negative. We don't have the results yet. As you can see, bevacizumab, again, we have a 9.5 month from Dr. Philip, who is here with us today at the conference, and 13.7 from Dr. Kasib. This is, again, however, was updated by a combination of sorafenib and erlotinib, if you jump all the way to the top, at ESMO, Dr. Zhu, 8.5 months. Then bevacizumab, again, as you see, 8 months, and sunitinib, 7.9 months for the phase 3 trial. Sorafenib 10.2, 6.5, 10.7. So all what I'm trying to imply to you here, that we failed in trying to prove that any more potent anti-angiogenic will do better than sorafenib. Which in other words, it appears that the median survival on sorafenib or any other anti-angiogenic therapy is 10 months. This is the ceiling that I'm trying to introduce, and the question is, why? With this said, there has been no doubt some efforts to overcome that ceiling. One of them is to combine therapy. One of the concepts that was developed by Lee Ellis and June before is to combine an anti-VEGF with an anti-GFR. And as you can see in the yellow line, CD31, which is a good marker for blood vessels. If you put in the two drugs together, which is the last picture in yellow to the right, you see that the numbers of blood vessels really go way down compared to the drugs alone or to the control. Which means that probably if we combine them together, we'll have an improvement in outcome. Nicely said, actually, this is from Dr. Kasib from MD Anderson, 13.7 month median survival in a phase 2 trial versus 7.2 for the PFS, which is, again, quite exciting. However, this is still would need a certain validation. A phase 2 randomized phase 2 trial is still ongoing, randomizing patients to sorafenib versus bevacizumab, 120 patients. This is not complete yet. Interestingly though, as I mentioned before, at ESMO there was a report from Dr. Zhu on sorafenib versus sorafenib. As you can see over here, sorafenib 8.5 months, and for sorafenib 9.5 months. It did not work. In other words, still we are in the same plethora of the 10-month median survival, despite that the biology tells us that you can combine those two therapies. So if biologics are not really able to bypass that ceiling of 10 months, could chemotherapy do it? And this is where our work started. Actually, on the same day the SHARP trial was launched in Florida, we launched a trial combining doxorubicin sorafenib versus doxorubicin placebo. Why doxorubicin placebo at that time? Because remember, there was no standard of care, and doxorubicin was kind of understood as being the standard of care, and it was an appropriate comparison, I would say. Patients, of course, maxed out on the doxorubicin because of the concern about cardiac toxicity, and patients continued on sorafenib versus placebo, with the primary endpoint being time to progression. But on the other hand, we also looked at different endpoints as deemed necessary to compare the two arms. Well, to our very great surprise, and so I can keep focused on the subject of overall survival, if you focus on the Kaplan-Meier right in the middle, you see that in the dark line, the median survival for the sorafenib plus doxorubicin was 13.7 months, and the doxorubicin placebo was 6.5 months, quite significant, p-value 0.006. Obviously, that 6.5 months is commensurate with the 6-month median survival I told you about. This is what historically we know. And the question is the 13.7 month really sorafenib plus doxorubicin, or is it a nicely selected population of patients with sorafenib? This is where you will be able to answer that based on some biology. This is a concept that we introduced. It appears to me that there's a molecule called ASK1, which is floating in the cytoplasm. And whenever you have a stressor, a stress could be anything, including doxorubicin, including anthracycline. If it happens that the anthracycline is given, ASK1 should help it to cause apoptosis and death to the cell. However, in HCC, ASK1 bind with RAF, and as you can see, this dimer actually sits in the mitochondria, rendering ASK1 not available to the cell upon the exposure to that stress, and the cells will survive. And as such, that's why, despite our efforts of continuing to give doxorubicin, it didn't work for many years because of that phenomenon. The question is, by combining it with sorafenib, and sorafenib, because it's a RAF1 inhibitor, could we release that dimer, make ASK1 again available, and as such cause the apoptosis? How are we going to answer that? This is actually the current NCI-sponsored study. It's called CHB 80802, which is randomizing patients, of course, to doxorubicin sorafenib versus sorafenib. This is the only way we'll be able to tell if doxorubicin is adding something to that phenomenon or not. That study is very critical because this is the first NCI phase 3 trial ever in HCC. And it really kind of like will declare our presence on the global map in regard to HCC in the US. Currently it's open in about 292 sites in the US and Canada, and we're about to open in Ireland with the sponsoring of the Irish government and the US government. We reached already the cutoff point for the first interim analysis at 170 patients. We're working on it, and we'll see how it's going to evolve. This is, by the way, as being the chair of the study, also we embedded the work of Larry Schwartz and myself in regard to tumor necrosis, so this is going to be part of that nice study. With this said, the question is, pending only piece of work still in the making, which is the doxorubicin sorafenib, I go back to the question, does really the anti-angiogenic ceiling exist? Is it really this what we are targeting when we are using sorafenib? And I'll take you through a little bit of an interesting exercise over here. If you recall from the SHARP trial, the median survival was 10.7 months versus 7.9 months. And you see it in the whole study population. Well, interestingly, and this is very important for Saudi Arabia, for a Hep C population, the median survival actually goes all the way to 14 months on the sorafenib in that study, while for the placebo it's 7.4, didn't change. So in other words, placebo virus effect, there's nothing, but clearly if a patient has hepatitis C and they're given sorafenib, they will pull a little bit more advantage from it compared to the general population. Well, interestingly also, in the Hep B population, this was just reported by Jordi Bruce in June 2012, the median survival of sorafenib is 9.7 months. A tad lower from the whole population, and the placebo 6.1, probably some contribution over here as well. Well, we were actually kind of like noticing this for a while. Actually, based on the phase 2 study, we started in clinic feeling that patients with Hep C do better than the Hep B on the sorafenib. So we did a retrospective look. I will warn you, this is extremely limited, retrospective, that was done with a fellow trained with me from Mexico City, David Woodson Melendez. And at that time, the median overall survival for the Hep C pure was 12.4 months, for the Hep B 7.3 months, and for the whole study population was 9.2. So clearly, the Hep C patients do better, and the Hep B patients do a little bit worse. The question is why, of course. So, I'll kind of give you a little bit more convincing evidence, and I'll tell you why. So, if you recall, I mentioned a study called the sunitinib versus sorafenib. This was done by Andy Chen from Taipei. And in that one, it was a randomized phase 3 trial, of course. As you can see, the sunitinib median survival was 7.9 months, and the sorafenib was 10.2 months in the blue. Well, actually, that 10.2 months is almost similar to the SHARP trial 10.7 months. Actually, I call this in a way SHARP 2. Well, even though the study is negative, the 10.2 month, or the curve of the sorafenib is of extreme importance to us, because nowadays, if you ask me, what's the median survival of sorafenib, I'll tell you who's the patient. Because from that sunitinib study, it appears to be if the patient has HCV, and they are ex-Asian, in other words, they are not from Asia, 18.3 months. That's pretty impressive. Then on top of that, if a patient has HPV and from ex-Asia, it's 15.3 months. HCV from Asia, 12.6, and drops all the way down to HPV in Asia for 7.9. The question is why? It appears to be, remember that RAF I told you about, like how it interacts with ASK1? Well, actually RAF, and hepatology will know, is actually excited by HCV core protein 1 of the hepatitis C virus. And in other words, whenever the hepatitis C virus is there, RAF goes up. And the question is, could it be that after all, and we know sorafenib is not the most potent anti-angiogenic, but because it's anti-RAF, could it be that we're seeing some anti-angiogenic effect, but also on top of that, some anti-RAF activity that's of course more present in HCV versus HPV? That can explain part of the story. Of course, now we have the issue of ethnicity over here. What's so special about Asia versus ex-Asia? This is something that we're trying to understand based on some genomic work that we're doing with Asia, as well as some other cohorts, which, by the way, I will reach to some of you to talk to you about it. We're doing it with Egypt, we're doing it with the Marshall Islands in the Pacific, we're doing it with Asia, with Taipei, with Ethiopia, and we'd definitely love to work with you on that as well, trying to understand the pharmacogenomic of the population in Saudi Arabia for that purpose. And this is really where I illustrated again one more time. As you can see here, we have the anti-angiogenic to the right, but we have the RAF inhibition to the left, which I would say we're a little bit kind of, forgetting about in sorafenib, but probably still play a major role. So, that's a little bit complicated, but just kind of give you a little bit of a flavor about how this is supported. Well, interestingly, in April last year, the Nové group published their data on the biomarkers of the SHARP trial. And as you can see over here, they found that actually angiopoietin-2 and VEGF, which of course are the markers for anti-angiogenesis, were not correlated with any outcome in regard to the sorafenib treated arm. Actually, just to kind of guide you through here, A and B are actually for the whole population, and C and D are for the placebo group. And as you can see, it's a prognostic for the outcome, but it's not guided by the outcome using sorafenib, which tells you again or support the anti-RAF activity component that I'm talking about. So I fill the gaps. Last piece I'm going to tell you about before we wrap it up. Last year at ASCO was quite exciting. There were two drugs that were introduced. One of them is cabozantinib, which, as you can see over here, it's an anti-CMET, and it's a CMET antibody, but it's multikinase. It was given to patients with HCC. This is what we call a discontinuation randomization study. Patients did well and responded, continue on the drug. Patient who progressed, they stopped the drug. Patient who has stable disease, then you randomize them to continue versus to have a placebo, with the idea to see if the effect of the stability was due to the drug or not. The median survival of that study was actually 15.9 This is in second line. That's quite interesting. So clearly there's some signal over here that c-Met activity might be important. Well, there was another one called tivantinib. And tivantinib, as you can see over here, was again given to patients in second line study, randomized tivantinib versus placebo, with a crossover only from the placebo to tivantinib on progression. And two important points over here. For the first time, we were able to show that MET, same way I'm talking about TRAF, is a prognostic factor, an independent one. As you can see here, the MET high versus MET low, and this is in placebo only, have a difference in outcome, 9 months for the MET low versus 3.8 months for the MET high. On the other hand, in regard to overall survival in the MET high patients, as you can see over here, tivantinib 7.2 months versus placebo 3.8, which means, in other words, yes, if the target is there, c-Met activity, then clearly there is an influence and patients will live longer in the c-Met high. We'll almost double it. What's happening with those two drugs? Interesting things are shaping themselves in the world the way they should probably. Actually, tivantinib is being led in a phase 3 trial by the Barcelona group, and ourselves were leading the phase 3 trial for the cabozantinib. So we'll see where these will take us. However, it's very important to note over here, even though we're doing this in second-line study, interestingly, again, I go back to the Love data from April, a very intriguing concept that actually, in that slide, the angiopoietin and VEGF, the fact that they were actually on the high side in the placebo, interestingly, c-Met was also on the high side in the placebo. And the question is, could it be that there's a population also that's c-Met high that we can serve in the first-line setting? Why do I say that? Because custom-made therapy is as follows these days. Based on what I showed you, yes, you can divide the etiology Hep B versus Hep C. You can divide this the Asian and Asian, at least for now, this is how we're seeing it. You can put c-Met high, c-Met low. And interestingly, out of nothing, instead of having one whole box at the bottom called sorafenib, just by 3 variables, already have 16 different possible therapies. And this is where we're going. This is how we're seeing the disease. I would not be surprised if the future trials even will start either stratified that way or even being randomized that way. We will see where it takes us. 2, to summarize, anti-angiogenic ceiling may have been reached or never been there. This is quite a challenging concept. Well, you'll see it in Lancet Oncology, I think, in the next week or so, I'm talking about it there. c-Met provides the first enriched population approach to therapy. Quite intriguing, and definitely this is what we're going to be busy for the next 5 to 10 years. And permutations of custom-made therapy are not that far away after all. And this is really, it's amazing that within 10 years, look where we are as a community in HCC. I thank you very much for your attention, and of course, I'll be happy to take any questions. Thank you.
Thank you, Dr. Abad, for this great talk. I would like to open the floor for questions. I have a couple of questions of my own, if you don't mind. As you said, most of these patients, they will start on sorafenib till they die or the disease progress. And from my experience, it's not uncommon to have intolerance or side effects to the treatment. I'm interested to know what's your approach. Would you just halve the dose? And is there any benefit from that, or just stop it? And how do you take it from this because of these frail patients? The other thing, I'm really looking forward to see the results of the ongoing trial of combined doxorubicin versus sorafenib alone. And I'm just wondering, are you guys facing any adverse side effects from doxorubicin, and what's the toxicity related to that? And if it's high, did you guys consider giving doxorubicin locally to the liver through drug-eluting Bs or?
Good. Thank you very much. These are 2 excellent questions. So in regard to the first one, and the issue of toxicity and management of toxicity in sorafenib, if I take it that way, yes, no doubt that the drug is not necessarily always tolerable, and there should be some quite good attention in regard to the management. The main 3 side effects that can occur, grade 3 or more, in sorafenib are Handful syndrome, which is a drug-limiting toxicity. It's a little bit of tingling, grade 1, gets into redness, grade 2, ultimately peeling, grade 3. The other one is fatigue, and should not be undermined in any way. And the third one is diarrhea. The approach that we take is close follow-up. And what we do is, despite its we really urge the patients to come within a week to the clinic. And in addition to that, we like them to at least call us or email us some pictures within 3 to 4 days. It all started, actually, we had a patient who comes, believe it or not, all the way from Lima, Peru. Our referral circuit is about 3,500 nautical miles in New York. And of course, bringing that patient back and forth wouldn't work, so we asked them to take pictures for us. And it works. Patients like to be involved, they like to take the pictures, they send it to you, the nurses look at them, and they send back and say, reduce the dose, up the dose. So I would say probably the key element is close follow-up rather than, here go, take the pill, see me in a month. It can't work that way. The other thing is you should be very receptive to reduce dose. It's not the end of the world. Actually, as you know, the full dose is 400 grams twice a day. A lot of doctors are practicing, and I know in Saudi Arabia, actually, some of them are practicing starting at 400 milligrams daily. And by the way, in the US are doing the same. I personally still go on the full dose with the intention to reduce if I have to. And obviously, in addition to the reduction in the dosage, supportive medicines are critical. As you know, in regard to the hand-foot syndrome, there was a piece of data from Dr. Ren from Fudan University in Shanghai, looking at the anti-keratosis creams as a preventative measure. I think it's safe, why not? Antidiarrheals, and of course some kind of like cycling for the sleep patterns and to help fight the fatigue. To answer the second question regarding the doxorubicin, you're absolutely right. No question, you are familiar with the data. We had some issues in the phase 2 study. Mainly, we found that about close to 20% or 19% had all-grade cardiac toxicity in the combination. And there's no doubt a certain synergy because we didn't see as much in the doxorubicin. However, the reassuring point is that almost 90+% of those were grade 1 or 2, which means we saw it on the MAGA scan or the echocardiogram, but we did not see it on any clinical changes with the patients. So obviously we're concerned. So in the phase 3 trial, which I showed you, CLGB 80802, we adapted a program where actually patients will have a close follow-up with MAGA scans. But in addition to that, we adapt what's called 24/7 monitoring. Actually, I'm available 24/7 myself with the statistician. And if I see any reported cardiac toxicity, we add it, and we have a moving point. If we believe at some point that we should be concerned, we'll of course stop the study. The good news is with 170 plus patients so far, it did not happen, so at least we have some reassuring point. One important point, please, as much as I'm promoting something that looks quite exciting, the fact that it's not yet approved or proven in the phase 3 trials, I urge you not to use it in the clinic. It requires a lot of attention, a lot of follow-up, and frankly, we don't know even if it's 100% works or not. Nice thing, by the way, we observed that patients who fail sorafenib in first line, if you keep the sorafenib and doxorubicin, will also respond again. And we have a clinical trial that's going to open next week at Memorial that will be looking at that as well.
Thank you so much.
Thank you, Dr. Abalfa, for a brilliant presentation. Two quick questions. The first one is you've demonstrated that patients who are ex-agents compared to agent patients with Hep C show inferior response to sorafenib. Are you aware of any studies that actually looked at the genomic distribution of Hep C patients in those studies? That's the first question. The second question is the SHARP trial included, as I understand, most patients were child A patients, but there were a segment of those patients that were child B. But I'm facing a lot of resistance from some oncologists when I refer them to sorafenib. So what do you feel about also having child B patients treated with sorafenib? Thanks.
Excellent points. The first one actually is one of my favorite is what do we know about Hep C in the population of sorafenib? Well, sadly, believe it or not, on the SHARP trial, this was not measured. However, the good news is we knew about it ahead of time. In CLGB 80802, as there is a sorafenib arm, we're doing actually a measurement of hepatitis C viral load and also looking at the quasi-genetics of hepatitis C at baseline and at equivalent points to RVR, SVR, like rapid virologic response, sustained virologic response. And hopefully this will give us a little bit of an adaptation and understanding of what does that mean. The good news is that this data is collected and we have it available. And interestingly, there is a piece that was published by the University of Southern Florida that showed actually that not only that you can influence with the presence of the hepatitis C how RAF is expressed, but it could be that sorafenib has an antiviral effect as well. So we're going to be looking at that as well. The second point regarding charts to AB, yes, you're right. Actually, it's quite intriguing, and that's why you noticed I mentioned at least briefly at the beginning. I said that we included B because we didn't know. As you know, we had a publication coming afterwards, and we were very clear that actually Charles B patients might actually get more ill on the drug. We're not sure yet why, because as you know, the Charles B is more of an exponential curve, and it could be that we're catching a little bit on the high up of the curve. But nonetheless, ascites, encephalopathy, and increased bilirubin have been noticed to be much higher in that population. My personal recommendation, it does not mean this is what's applicable everywhere, and this is based on that observation that we reported. In addition to a study that we did called CLGB 60301, looking at the organ dysfunction population with sorafenib. Patients with bilirubin 1.5 to 3, I give half the dose. Patients with bilirubin above 3, I will probably don't recommend sorafenib. And for patients with an albumin below 2.8, I will give only 1 pill a day. These, by the way, based on our publications, were adapted by the government of Canada. And as you know, for example, in Canada, sorafenib is only available for Charles B. Personally, I would say caution and bilirubin management will be appropriate to help out in that decision making.
I'd like to ask you, Hassan, what do you think about using sorafenib, first of all, as an adjuvant setting after resection of vascular carcinoma, number one, and number two, what do you think about using sorafenib after TACE, after transactive immobilization, considering the stone trial, which is already ongoing?
Great points. So in regard to the use of sorafenib in the adjuvant setting, the study is already complete, as you know, and we're waiting for the results. So far, I would say we cannot recommend it until we await for the adjuvant trial to be reported. The concept does make sense because, no question, we all know whenever we cut through the liver, angiogenesis revs up, and others using a certain anti-angiogenic therapy might be applicable. However, we have to wait and see. The TACE has been a quite rough course. As you know, it all started with the TACE followed by sorafenib versus placebo by the Japanese and the Koreans. And Dr. Kudo reported that at ASCO about 3 years ago now, and that study was negative. The argument was that this rev-up angiogenesis I'm talking about happened literally within 24 hours of surgery or TACE, while at that time, because of the misunderstanding of safety or lack of understanding of safety, they waited too long, about 9 weeks. And as such, probably we missed the point of trying to exert some effect on that angiogenic rev-up that's happening. So there was another study, as you know, called the STORM study, and this was reported again by Lencioni from PISA, and this study was again negative. And despite that, this was really a clamped sorafenib before and after TACE. We're not really sure what that data means. Despite that the Hopkins group has shown safety in that regard, if you recall, there was an editorial that I was invited to write in JCO for that purpose, and I still insist that, yes, this is a marriage, it's not a divorce in regard to TACE and sorafenib. But however, I don't think we really are measuring it correctly, and this is one of the points that Jordi Bruce and I would agree upon, that the TTP, time to progression, is not necessarily what we should be looking after. I have to say though, there is another interesting concept that we are currently moving on with the TACE Plus, is actually a immune modulator. Rather than focus on the anti-angiogenic, we're looking at immune modulation. Actually, we're looking specifically on the anti-CTLA4, same way like in melanoma. And we're having a study that hopefully will happen at some point where we're going to do the TACE followed by CTLA4 and the anti-CTLA4 agent. So we'll see where this will take us. But for now, again, I do not recommend the use of sorafenib after TACE because the data does not support that. Despite it's safe, but we don't have the proof to improve on outcome. Any other thoughts?
Okay, that will bring us to the end of the first lecture. Thank you, Dr. Awal.
Thank you very much.
That will take us to the next speaker in the next talk. Our next speaker is Dr. Hisham Akbar. He doesn't need any introduction. He's a well-known assistant professor in the Department of Gastroenterology and Hepatology, King Abdulaziz University, not only in the university, in the whole city of Jeddah. Dr. Hisham Akbar, he's a graduate of this fine university. He did his postgraduate training in different places in Canada. He came in and started a heavy hepatology and a gastroenterology service, serving a big piece of our community. He's involved in resident teaching and evaluations, and also his major research and interest is in the follow-up of patients with hepatitis and early diagnosis of hepatocellular carcinoma. Without further ado, please, Dr. Hisham Akbar, the podium is yours.
First of all, I'd like to thank Professor Mahmoud as well as Dr. Shadi for inviting me today for this nice symposium. My presentation today is going to be screening and diagnosis of hepatitis C in patients with viral hepatitis. We know nowadays that hepatocellular carcinoma is the 6th most common cancer worldwide. It is the 5th commonest cancer in males, as well as the 8th commonest cancer in females. Nowadays, mortality from SCC is increasing, and we know also that hepatocellular carcinoma is the 3rd cancer-specific cause of death in patients with hepatocellular carcinoma. And in UK, we're expecting in 2020 that the mortality rate will increase up to 14% from hepatocellular carcinoma. If you look over here at the global incidence, the areas where we see commonly hepatocellular carcinoma mainly in China, in sub-Saharan Africa, Middle East, and Egypt. Egypt is number 1 among the Arabs having hepatocellular carcinoma, and Saudi Arabia follows Egypt as far like incidence of HCC. 90% of patients who have got hepatocellular carcinoma, they do have underlying liver cirrhosis. And in general, we can say like almost 85% of patients with hepatocellular carcinoma are due to infection, either with hepatitis B or hepatitis C, depending where you're talking about. For example, Egypt, more than 99% of cases with hepatocellular carcinoma are due to hepatitis C. In China, the majority are due to infection with hepatitis B, and Japan is due to hepatitis C, and that's same for the Western region in America. When we talk about hepatocellular carcinoma, actually we're talking about 2 different diseases. We're having like patient with liver cirrhosis and HCC on top of liver cirrhosis. And in 10% of cases, you can have a normal liver and hepatocellular carcinoma on top of normal liver. Now, what about surveillance? Does HCC deserve to have screening or surveillance diagnostic technique? And the answer is probably yes, because suitable for surveillance probably for the following reason, because sufficiently is a common disease, as I mentioned already, is associated with substantial mortality. If detected early and treated properly, the mortality rate will decrease. We know the target population, patients who are infected with hepatitis B, hepatitis C, or patients who develop liver cirrhosis. Tests used for screening, are cheap, inexpensive, and accepted by the patient. And nowadays, the screening intervals have already been established or set up. When you talk about measures adopted for preventing hepatocellular carcinoma, we talk about primary prevention and secondary prevention. Just like primary prevention are measures designed to limit tumor occurrence. So if we vaccinate our population, like vaccination, now has been adopted in Saudi Arabia for the last probably 20 years, that would result definitely, the incidence of hepatitis B surface antigen, and in Taiwan has been shown, also has been associated with decrease in the incidence of hepatocellular carcinoma. And reduction of the viral load in patients with hepatitis B surface antigen using nucleotide low would also result in the incidence of developing hepatocellular carcinoma. And this is a study using lamivudine. If you look at the last bar, hepatitis C, hepatocellular carcinoma, the patients who were treated was only 3.9% as compared to placebo. What about patients who have got hepatitis C when they're treated with pegylated interferon and ribavirin? Patients who develop sustained biomarker response, they do have reduction in the development of hepatocellular carcinoma, as you can see in red. In different studies, patients who responded to treatment, SBR stands for sustained biomarker response. All these patients, they have got decreased percentage of SCC as compared to non-responders as well as the control groups. What about the patient did not respond, the patient was infected with hepatitis C who did not respond to interferon or pegylated interferon? Can we keep them ongoing on interferon? Actually, the HELP-C study did not show that the patient did not respond, that if you keep them indefinitely okay on pegylated interferon, that there will be reduction in SCC. And regarding secondary preventions, these are the measures designed to limit tumor progression to more advanced stage. To make it easy, is whatever measure you do in order to pick up the tumor at an early stage, that's when we can apply treatment and decrease mortality from SCC. Most of us now we use what are recommendations from the American Association of Study of Liver Disease, but still there are a lot of doctors who are practicing hepatology, they're using the EASL recommendation. But to make it easy, that we have to screen every single patient with cirrhotic, irrespective of the underlying cause, whether it's hepatitis B or hepatitis C. I always teach my medical student that if a patient with hepatitis C who developed hepatocellular carcinoma, you can say 100% this patient has got liver cirrhosis. However, patients with hepatitis B, if they are tested positive for hepatitis B surface antigen, they do have 100-fold increased chance of developing SCC as compared to control population who are negative for hepatitis B. But if these individuals develop liver cirrhosis, the chance of the risk for developing SCC decreased to 1,000-fold. So the aim, if you're going to follow the Barcelona Clinic BCLC, which is Barcelona Clinic Liver Cancer, we may be aiming to pick up the patient at stage A, early, when we can do something, we can decrease the mortality. This could be associated with survival rate of 70%. If you pick up the patient at that stage, you cannot do much. So this screening, recommendation of screening for patients who have got chronic liver disease is mainly to pick up the patient at the end stage to do something for the patient. What are the tests used for screening? If I'm going to ask my medical student, my colleagues, whatever, to say health protein as well ultrasound. If we talked 5 years ago and say yes, this is true, that's a recommendation. But last year, that had been changed by American Association of Study of Liver Disease. Now it's only ultrasound. Alpha protein is not sensitive enough, so even if you don't do it, forget it. Ultrasound, you have to do it every 6 months. In order to, you have on a regular basis, if the patient has got underlying cirrhosis with hepatitis C, and any patient with hepatitis B should be done if cirrhotic or if it's a high risk. If he's coming from Asia, if he's a male, it should be more than 50 years. Female more than 50 years, a male more than 40 years, and if he's coming from Africa, it should be about the age of 20. Is it positive family history of hepatocellular carcinoma? What shall we use? Ultrasound, CT scan, MRI. CT scan, MRI are used for actually establishing diagnosis. They are not used for screening. They are expensive. They are associated with side effect. So ultrasound still is the measure that should be used for screening for hepatocellular carcinoma. If we look to other guidelines on screening and surveillance of SCC, they are more or less similar to the American Association of Study of Liver Disease. The National Comprehensive Cancer Network is same as the SLD. They recommend using ultrasound, but on top of that, they still ask for alpha protein. They haven't changed every 6 months. And why using 6 months? Because the doubling time hepatocellular carcinoma is 4 months. The EASL, they ask for alpha protein ultrasound every 6 months. British Society of Gastroenterology, the same, abdominal ultrasound and alpha protein every 6 months. Japan Society of Hepatology, they are different. They ask for alpha protein abdominal ultrasound every 3 months, and they do also CT scan MRI every 6 months. On the contrary, U.S. National Cancer Institute, they don't believe in screening tools, so they don't advocate screening or surveillance for patients who have got chronic liver disease because they don't think it's going to change anything, okay, as far as mortality is concerned. Common question, okay, how do you diagnose a patient with SCC? Medical history, patient infected with hepatitis B, hepatitis C, not have chronic liver disease. Patient has been losing weight. Patient is clinically jaundiced. Abdominal distension, examination has got palpable mass. Blood test, okay, high alpha protein. X-ray, we're going to talk about, muscle mass liver biopsy. But 40% of patients with SCC, they are asymptomatic. And if we are going to apply properly a recommendation from SLD or periodic screening, we probably will get a lot of patients will still asymptomatic when they can be treated in the early phase. So, what does the American Association Study of Liver Disease advise as far as diagnostic criteria for SCC? While doing the screening, we're doing ultrasound, and that's we're doing it when the patient are cirrhotic. If you find by ultrasound a lesion in cirrhotic liver, which is less than 1 centimeter, recommendation, you have to repeat the ultrasound after 3 months. And keep doing it for the next 18 to 24 weeks. If this lesion, we're still talking about this side, if this lesion is still more or less the same, then probably you are not dealing with SCC, and then continue screening the patient every 6 months. However, this lesion, while you're doing this ultrasound every 3 months, is increasing in size, so according to the size achieved, you have to follow whatever line we're going to talk about next. On the other hand, if while doing the screening, the lesion was between 1 and 2 centimeters, you have to do 2 dynamic imaging, either a helical CT scan or an MRI. And ideally, if you see the characteristic rapid washout, either by CT scan or MRI, these are characteristic for hepatocellular carcinoma. But for the lesion between 1 and 2 centimeters, you have to have both CT scan and MRI showing this rapid washout. If you got this typical vascular pattern, then you are dealing with SCC and you can go ahead and treat without further investigation. But if this 1 to 2 centimeter lesion have got CT scan and MRI with atypical vascular pattern, or one of the tests is in keeping with SCC and the other is negative, it's not like characteristic of SCC, then you have to go for liver biopsy to confirm the underlying diagnosis. And this is not the case if the patient has got a lesion above 2 centimeters. If the lesion is above 2 centimeters and the CT scan or the MRI showing rapid washout lesions, then this is enough to confirm that you are dealing with SCC, no need for liver biopsy. And the EASL, they also add that you have also to have alpha protein more than 200 nanograms. Once you establish diagnosis with an X-ray with liver biopsy, then you decide what to do next. You stage the patient, and the staging adopted by the PCLC includes, first of all, the size of the tumor, second, the status, performance status of the patient, as well as the chart classification, as well as vascular involvement, and based on that you decide, are you dealing with a very early disease, early stage, advanced stage, and terminal disease, and you decide what to treat, which is beyond the scope of my lecture, and I'm sure we're going to hear a lot from my colleague in the next presentation. Now, if you discover a patient in the early phase, survival rate between 50 to 75 at 5 years, intermediate 16 months survival, advanced 6 months survival, and end stage, you cannot do much, survival rate is less than 3 months. There's increasing incidence of early stage, like in diagnosis SCC. In Japan, you can see when they applied the screening protocol in 2001-2004, 26.3% of cases of SCC were having stage 1, and 73.3% were having stage 2. In the United States, unfortunately, only 7% had no sequential tests reflecting actual survivals. And the majority of patients, which is like probably 72% who were diagnosed to have SCC, they never had screening survey, they never had an ultrasound, they never had a fit protein. Only 28% they had either of this. And this is actually the same, that's what's happening in Saudi Arabia. You see a patient, you know this is supposed to be screened, you advise them that, you have to have ultrasound, okay, I still keep doing that fit protein, but the patient, okay, they lose the follow-up, they understand what I'm saying, maybe show up again after 2 years, and I cannot face them and tell them, hey, listen, I'm doing this in order to rule out or to diagnose that there's hepatocellular carcinoma, because if I tell them so, it's unacceptable. He will not come again, he will try to find another doctor. So our patients, okay, I have to hide a lot of stuff from them because they will not accept if you're failing them, why you're doing this. Definitely do not accept it. If you tell them the problem is a son of the daughter, will say, why did you tell them? So you have to be cautious. So challenges daily diagnosis, lack of screening, same as what's happening over here, inadequate screening method, as you're doing as-fit protein, you're not doing ultrasound. In addition, you have to keep in mind, okay, a lot of patients, they go to X-ray department, they get ultrasound done, the technician is not like well qualified, whatever, okay, even the presence of the tumor or lesion, whatever, the ultrasound gets reported to be normal. Need to raise awareness of patient and primary care physician, so that's probably our job, okay, to go probably to the rural area to discuss with them that, hey guys, any patient surrounding, it's mandatory every 6 months, they have to have surveillance technique, ultrasound, and if it's not available, then have protein. In summary, early detection of SCC enhances survival. Surveillance recommended for patients at risk, especially those with hepatitis B virus infection and patients with cirrhosis. There's no difference in early detection rate with 6 months versus 12 months because initially people they thought that why not doing it like every 3 months? Maybe we can catch the patient earlier. Even the patient has got very high risk, even if you do it at 3 months, whatever. Patient with high risk, that does not mean that they have more rapidly growing tumor. No, that's not the case. They do have high risk for developing cancer, but not rapidly growing tumor. And prevention of SCC by antivirus therapy remains an open question. Even a patient who can develop like PCR negative for hepatitis B, still they have to be screened because negative PCR hepatitis B does not mean the patient is not at the risk of developing hepatocellular carcinoma. Patients with hepatitis C virus, if they develop SVR, they were not cirrhotic, probably they are safe. But they develop SVR and they were cirrhotic already, SVR will not decrease the chance of developing SCC. Still, these patients should be followed on a regular basis every 6 months of with ultrasound plus or minus protein. I'll stop over here. We'll leave the discussion.
Thank you so much. Thanks, Dr. Akbar. We'll allow for 1 or 2 questions just because of the time. Dr. Beirut.
Hear me.
It's enough for me.
No, stand there, please.
It's enough for me.
Listen.
The what then?
Yes. If I have $10 million and I will give it to you, you will do HCC screening or hepatitis B or C screening, or you will spend it on your own luxury life. What do you do with this $10 million? Which is more important?
$10 million?
$10 million.
I will take it and whisper the hospital.
Very good. That's what I wanted to. You are not doing anything.
No. If I do have a money and I want to implement it,
Use the microphone.
Dr. Akbar, please use the microphone.
I will tell you. If I do have money to implement it, I'll implement it primarily on the primary prevention. So if you can decrease the chance of getting or the prevalence of hepatitis B and C in our community, that will do a much better job, as compared to secondary prevention. Okay? Is that the answer you expected?
Yes. And the second point is hepatitis B and C is the only risk factor for HCC, or what about hemochromatosis? It's
Okay. 90% of cases, total cases of patient liver cirrhosis, they do have underlying hepatitis B and hepatitis C. But other diseases that can cause chronic liver disease, like patient with NASH, patient with hemochromatosis, patient with metabolic syndrome, underlying metabolic syndrome, patients with primary liver cirrhosis, autoimmune hepatitis, as well as alcoholic liver disease, also share develop SCC. But definitely, as compared to the general population with HB, hepatitis B and hepatitis C, at a much lower level.
Thank you.
You're most welcome.
One more question.
And Sham, thank you very much for the excellent presentation. I just want to tell you from our data from the National Cancer Registry. In fact, hepatocellular carcinoma used to be number 1 in 1994 in males. And now it is number 5. It's not number 2, number 3. It's getting less and less. And probably this is because of the vaccinations which started a long time ago. And that is a major achievement in our government. My question to you, each country will utilize the screening, according to their population. And even, what do you think about the US data? Because I don't believe that I should follow the same, recommendations of not doing alpha protein in our patients. Especially if we don't have a lot of studies to say what, the sensitivity of alpha protein in our hepatocellular carcinoma patients, it might be different. And if I'm still, which I still myself use alpha-15 ultrasound for probably high-risk patients, probably you do use it more. Which one will you recommend? I thought of doing alternating alpha-15 and ultrasound every 3 months, so every 6 months, I mean. So, but alternating, and instead of doing them at the same time, like I'll do alpha-15 now, ultrasound after 3 months, and then alpha protein again after another 3 months, and so on.
Okay, Professor Mahmoud, like when you talk about alpha protein, until now, we did not agree what do you mean by high alpha protein. Now, in order to balance the sensitivity and specificity of the alpha protein, we agreed that 20 nanogram is probably upper higher normal. If we increase this 20 nanogram to 400, let's say, nanogram alpha protein, then probably we're looking for more false negative, false positive cases, as compared to when we decrease the alpha protein. Sensitivity is still 60%. So a test with sensitivity of 60%, I don't think that's acceptable for most of the doctors using it. It's not expensive, but you cannot make much of it. And what's important about alpha protein is not the level itself. Because you know that patients are cirrhotic, they tend to have high alpha protein. What's important with alpha protein is the rapid rise, the persistent rising of the alpha protein or follow-up that probably will indicate development of malignancy. Regarding ultrasound, probably, I will agree with the American Association Study for Liver Disease that if we do have good technicians, I'll probably depend on ultrasound and forget about alpha protein because a less sensitive assay probably, and based on some other studies combining alpha protein and ultrasound, as compared to alpha protein and ultrasound I know, we're not like, combinations of alpha protein and ultrasound was not superior to ultrasound I know. So I probably will go for ultrasound and no without alpha protein. But let's say if someone is living in Jizan and they don't have a good technician, who does like ultrasound, all what they left is alpha protein. So it depends on the geography where the patient is living. In Jeddah, I probably go for like ultrasound I know. And probably in Jizan, I will go for alpha protein. But this alternating like every 3 months forever, I don't think it's going to help much. It's like, it doesn't add because if we do 2 tests together, was not superior to 1 test. So why like doing it in alternating tests, like alternating in ultrasound, whatever. It hasn't been studied, but I don't think it's logic for me.
Thank you so much. I have one last question of my own, Dr. Akbar. Is there any role of using PET scanning in the diagnosis and the follow-up and or staging of these patients?
Well, it's like most of the studies, they use the MRI. They use like for diagnosis, we're not talking about screening. They use MRI, the CT scan, and they use also the ultrasound, the imaging ultrasound, with the radio contrast, which is not approved in the States, only approved in Europe. If you're going to do something, it should be cheap test, relatively cheap, something available. Probably in Saudi Arabia, probably MRI should replace the CT scan, but it hasn't been studied by whatever staging technique or staging method we're using, where everybody is using BCLC, and SPECT is not included at all. Theoretically, what you're saying, probably you can do it. But has it been started? No.
No, okay. Thank you so much, Dr. Akbar. With that, we conclude this lecture and we move on to our next speaker. I would like to welcome Dr. Majid Ashur to the podium. He will talk with us about the minimally invasive or non-surgical therapeutic intervention of hepatocellular carcinoma. Dr. Ashur is the Deputy Chairman of Radiology Department at King Faisal Specialist Hospital. He's another graduate of this fine university. He did his postgraduate training in the University of Ottawa, where he did general radiology and interventional radiology. His research interest into oncology intervention and venous intervention. The podium is yours, Dr. Ashur.
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم. Thank you, Mr. Chairman. I'd like to thank Professor Mahmoud for the invitation, and it's my pleasure to share my experience and knowledge about minimally invasive treatment of liver cancer. I think the first two lectures helped me a lot in starting my lecture, of course, because they complement each other. As it was mentioned that liver cancer is the sixth most frequent tumor worldwide, and is the third most frequent cancer-related cause of death. It's been estimated around 500,000 deaths per worldwide happens yearly from liver cancer. And in Saudi Arabia, it's 6.1% of all newly diagnosed cancers are actually liver cancers. And it's been also estimated that the prevalence is around 4.5 per 100,000 population. Now, when we talk about treatment of cancer, we have to talk, of course, about what are the options. The options could be a surgical resection or liver transplant, and in the next lecture we're going to probably hear that. And then the minimally invasive part, which is composed of mostly percutaneous ablative therapies or transarterial chemo or radioembolization. Of course, the medical therapy we read about it in the first lecture. And I think the most important thing is a combined therapy. Could have combined most of the above discussed procedures. Now, when we talk about also treatment, we have to think of what kind of stage of liver cancer we are talking about. It's peculiar, as was mentioned by Dr. Akbar, that we're dealing with two different diseases, liver cirrhosis or underlying liver disease, as well as the cancer itself. So these have to be put in account, of course, the overall patient conditions. Those stages, there are lots of stages being followed worldwide. Some surgeons, of course, prefer certain criteria, oncologists for others, but we follow mostly the Barcelona criteria of staging because that's more applicable and practical to our type of patients. Now, it is more clinically oriented and it takes into account the tumor stage, the liver function itself, and the patient's performance status. And it clearly separates the early from the end stage disease. Now, if you look at this BCLC staging system, it's been staged into stage 0, which is a very early cancer. Talking about a single lesion less than 2 centimeters. For stage early A and intermediate B, this is the stage where usually we intervene here as intervention radiologists. So what are the modalities we have to treat liver cancer? There could be a percutaneous ablation therapy. Early on in our experience, we used to use ethanol as a sclerotherapy or ablation therapy. But since 2003, we stopped using ethanol and we are using radiofrequency ablation. And it's already been published that radiofrequency ablation is as the standard kind of percutaneous modality. Transarterial chemoembolization, again, we started very early with using the Levite or the doxorubicin combination, but nowadays we move to more advanced using drug-eluting beads. Radioembolization is probably started only a couple of years ago. We are already phase 3 ongoing. We don't have the data published yet about it. So the ideal lesion to treat the liver cancer with radiofrequency ablation is a 3 centimeter or less size lesion that's completely surrounded by liver parenchyma. It's 1 centimeter or deep the liver capsule and is 2 centimeter or more away from large hepatic vessels, portal vein or hepatic vein, because we don't want to get the heat dissipation by the flowing blood adjacent to it. Now, however, the indication could be for those patients that are not fit for a transplant, but they are transplant criteria, like plan criteria patients. Solitary lesion less than 5 centimeter or up to 3 lesions, each of them is less than 3 centimeter. And also we can use RF ablation in combination with transarterial chemoembolization for more than 5 centimeter lesions. In general, the contraindications, any significant coagulopathy, that's very important to us. Of course, sepsis or portal vein thrombosis, child C because of the nature of the disease itself. Many machines are available in the market. Many machines, more than what I'm showing here. But every machine deals with a specific kind of a criteria and the ablative therapy. Some machines deals with how much heat you want to deliver. Other machine looks at tissue impedance. And other third machines will look into how much power of energy you're going to deliver. But all machines have been tested and it depends on whatever center. Some of them have some advantages than others overall. The techniques, we can use ultrasound guidance, that's the commonly we use. If you can see the lesion, it's very fast, safe, and no radiation. Of course, if you can't see it, then we can use a fluoroscopy in angio suite, or we can use, of course, CT guidance to ablate these lesions. Now, it's been well published that we look at our results by how much necrosis we produce inside the tumor. And it's been known that if a tumor is less than 3 centimeters, we can achieve complete necrosis more than 90%. And of course, if the size goes larger, our percentage of complete necrosis, of course, will decrease. And that's why now the combination therapy has been the modality of choice for anything above 3 centimeter lesion. Now, this is an example of a mass located at segment 7 in the liver. You can see the mass there. It's around 2.2 centimeter. We could utilize the ultrasound or CT. Again, if we can't see the lesion very well by ultrasound, then we utilize CT. And you can see this, the RF needle. Just point. Do you have a pointer here? Anyway, so we can see the RF needle in the lesion. And this is a follow-up here, 6 months post-RFA. You can see the lesion as well hypovascularized, complete lack of contrast enhancement in both arteria, with no washout or any kind of possible lesion in the delayed phase. So now we achieve complete necrosis here. We always wanted the necrosis or the ablation size to be larger than the size of the mass itself. An example of a patient had 2 lesions, 2 small lesions. You can see one in segment 4A and the other one in segment 7-6. And we can use that ultrasound. If you see, you can see them by ultrasound, the 2 lesions, then we can ablate them as an ultrasound guidance. Commonly, we see this kind of echogenic or the white kind of echogenicity in ultrasound during ablation. That's because of the micro bubble produced during the thermal ablation. And you can see a 6-month and 12-month follow-up of those 2 lesions. This is sort of a peculiar, unique patient. She has hepatitis, but she doesn't have the cirrhosis. She is a very healthy lady, and you can see a small cancer in the MRI, measures only 2 centimeters. And that will be really fit and a good candidate for surgical resection. And the daughter of this patient is a physician, and she trusted so much the RF that she wanted to have an RF. So of course, we do an RF, next day she goes home, and we have, I don't have the images, now she's 4 years post-RF for a small lesion that is supposed to be a surgical resectable lesion, but we have excellent results. So we always expect to see a scar at the side of the ablative lesion. Now what about TACE? TACE is indicated for intermediate disease, mostly stage B or multifocal. We can use it, as I mentioned, in a combination with percutaneous treatment. And nowadays we're using it more and more for bridging for liver transplant, or patients are waiting for liver transplant, or even downstaging a borderline liver patients, liver transplant candidate patients. The contraindication for TACE is well known, portal vein thrombosis. If there is a portal vein thrombosis, TACE will harm the patient significantly more than the benefits. Of course, at stage child C, of course, we don't do that. or if the tumor burden is significantly in the liver. It's been studied that taste is very effective, and in this study, 80 patients were randomized to receive taste versus medical treatment, and the survival rate, you can see, significantly in favor of taste group in the first, second, and third years, of course. Another meta-analysis of several randomized trials for unresectable HCC has been published also, showing the 2 years mortality were much more significant in the control group than the taste group. And this meta-analysis has shown that taste is the only therapy in HCC that has had reduced mortality in selected patients. So this is considered to be a mid-term effective therapy for non-operable HCC. Now the problem is that almost majority of the patients, they get the post-embolization symptoms. They will be sick a little bit, they have a right upper quadrant pain, vomiting, nausea, fever. It could stay for a day or two, and some patients can stay for up to 5 days. And it's been also reported a major serious complication of even death related to the taste procedure itself. The mechanism is probably known to everybody. Is you block the vessels, you cut the blood supply, and the doxorubicin or the chemotherapy stays longer in that lesion. And of course, the toxicity of doxorubicin giving it transarterially compared to systemic is much significantly less. This is the classic material we use, lapidol with doxorubicin, and nowadays more we are using drug-eluting beads with doxorubicin. This is an example of a patient with HB hepatitis and have a very large 9 centimeter mass seen in the dome of the liver here. This is classically what when we do taste using lapidol. Lapidol is an oily contrast material, so when we inject, we see it. And you can see this trapped lapidol with the doxorubicin emulsion in the tumor. And the end result, the last image, you can see this complete occlusion of the vessel with no vascular enhancement of the tumor. And this is what we expect to see in CT. Significant retention of the lapidol in the tumor, and the more the lapidol stays, we know that the tumor is dead. And once we start seeing some lapidol eaten or disappearing, we know that there's some active tumor again there. Example here of another case, it's a very large tumor, you can see, and this is post-embolization. And you can see here over several months, the tumor is shrinking in size. This is an example of a patient that when we did the first session, it's a 7.3 centimeter mass in the dome again, it's a large mass with the taste. And in the follow-up, you can see half of this tumor only retaining the lapidol, and the other part of it is still vascular enhancement. So this means that this patient will need another session of taste. I usually do the first follow-up is 6 weeks after the taste, and then another 6 weeks will mean 3 months from the taste. And so if we give another session, we did expect that we would kill more tumor. We don't have the image, but we have also the angiogram showing the complete avascularity of the tumor. Now, combination therapy, the hypoxic effect that results with the chemotherapy from the taste, if you add the heat that can be produced by the RF ablation, we're probably going to achieve much more tissue necrosis than what we expect from a single kind of modality. It's been reported that RFA for any mass that is more than 5 can achieve a complete necrosis in only 30 to 45%. But if we combine taste with RFA in those kind of patients, we can achieve up to 80% complete necrosis, tumor necrosis. This is an example of a patient with a 5.6 centimeter tumor, again in segment 7 and 8 of the liver. And you can see the tumor enhancement there. We did first the taste, and then we followed up, this is post-taste. You can see the retention of the lapidol in the tumor. And of course we can use, since the lapidol is radiopaque, and for this huge size tumor, it's sometimes very difficult to control your needle position by ultrasound. So we use the combination of both ultrasound to position and also the fluoro to look at if your electrodes of the RF needle cover the whole entire lesion. So we can do the same lesion at 2 or 3 different sites in the same sessions. And you can see here the result for 6 months. Complete retention of the stage, very homogeneous, very dense with inactive tumor. This is another patient again, majority of our actually liver cancer patients, we see them down segment 8 or 7. Another patient with a 8 centimeter, with a 5.6 centimeter lesion, you see the enhancement there. Again, we did both combination of TACE as well as RF. I usually try to plan the RF 2 days after 48 hours, but if the patient is so sick after TACE, we usually discharge them and bring them after a week or 2. So this is 1 year after, there was no recurrence. However, 24 months after, we can see a small nodule again appearing here that we can easily tackle with a small RF needle. So we can, the beauty of RF, of course, is we don't have to open the patient again, just put a needle there and burn the tumor. This patient was a liver transplant candidate. He has a small, nice lesion, segment A. So we did a TACE in order for him to wait for his transplant. So he had the TACE, and we had the follow-up, and unfortunately this patient was rejected from the transplant after he went to France. And the reason he said he had a cardiac disease that he could not tolerate the liver transplant. So we ended up doing also, of course, RF. We try not to do RF for patients that are liver transplant candidates. I'm going to look at some data regarding the combination of both TACE and RFA for unresectable cancers. Many data has now been published talking about the combination therapy, and mostly for patients having liver cancer 4 centimeters or above. So this study looked into 46 patients with 51 unresectable lesions, and the diameter of the lesions ranging between 3 to 8 with a mean of 4.8. So 27 lesions were less than 5 centimeters. And they did RFA performed on between the same or the 4th day of TACE. And they did a follow-up as we standard we do, 6 weeks, 3 months, 6 months, and 12 months, 18 months, every 6 months that we do usually that. They found that a complete lack of contrast enhancement in 66.7% of the lesions. And they found that again, the smaller the size of the lesion, the likelihood of you are getting more necrosis. The larger the lesion, the likelihood you might have some part remaining enhancing the tumor. They found the survival rate at 12 months was almost reaching 90%, and at 24 months was 67%. They had procedure-related mortalities. They had also some patients who had distal metastasis and progression of the disease. In another study where they looked at, they treated 108 lesions, and again here, majority of the lesions were less than 3 centimeters. Now they looked at this, they said complete necrosis happened in all lesions regardless of the size. So even for a 12 centimeter lesion, they did show some images in their articles. They found no local recurrence for small and intermediate lesions. However, 20% local recurrence for the largest lesions. So in spite of achieving a complete necrosis, we still might see, of course, local recurrence around the tumors. Now, what about the drug-eluting beads? Now, when we use the Lapidol, we use the doxorubicin emulsified to the Lapidol. The doxorubicin will coat the Lapidol and will go. Now, for this kind of material, it's like particles that we use regularly for embolizing any vessels. But these particles come in a dehydrated phase. So what we do, we inject this chemotherapy inside this vial that contains dehydrated particles, and these particles will then absorb all the doxorubicin inside. And then it comes that the doxorubicin will be carried within these particles. So it will stay, theoretically, and also in vivo, in vitro, if it's found, that it will stay longer in the tumor, and it will have much less kind of concentration in the plasma host. This is an in vitro study, just demonstrating that the amount they loaded, of course DCB is what we're talking about. The amount they loaded is equal almost to the amount remaining within this material, even after 24 hours. So significantly compared to the other kind of material. Also, here's the elution from the Lapidol, as you can see, the long curve. So after 2 hours, almost it's completely will be separated from the Lapidol, compared those doxorubicins trapped within the drug-eluting beads. Also in the plasma, you can see here the concentration. If you use with a black dots, if you use it with a regular lipid, it will just goes to the plasma very quickly compared to the drug-eluting beads. Now, several studies has been already been published now using the DE beads. This study is from Italy. They looked into 61 cirrhotic patients with unresectable cancer and 30 patients with a mean tumor diameter of 5.4. They used the DE beads versus other group that they only used the conventional taste, and they found that disease progression is much more in the conventional taste compared to the drug-eluting beads. Another study was published in Greece. They looked at they treated 62 cirrhotic patients, and again they found that the tumor necrosis was achieved much more with the DE beads group, and the survival, the 1 and 2 year survival rate were also significantly higher. And the survival of patients with CT by EDC bead in this study, where they looked at, they treated 104 patients with DE bead, majority were child A, and they found that the median survival was 48 months. And however, of course, more significantly for the BCLC group A. This is an example of a patient who treated. This is a contrast enhancement study with a delayed phase. This is what it looks like when we use the DECB. So remember, with the lapidol it was very dense. Now with the DCB it's just a contrast material we're injecting. And so we combine that with the RF ablation. It's an ultrasound image showing the RF ablation there. And that's the outcome. So 1 year after, the tumor we treated in segment 6 is completely necrotic. But there is a new lesion now, you can see there in segment 8-5. So we treated also that lesion also with RF ablation, and you can see here 2 years after, both tumors are completely necrotic. This is a very interesting patient who presented to us to the emergency room, was referred from outside the hospital actually, and had a massive hypovolemic shock because she bled. And you can see the CT, there is massive high density material in the abdominal cavity, is blood, and it's very enhancing the tumor. So what we did here, we did emergency embolization, of course not using any fancy thing except regular PVA particles. We want to stop the bleeding. So we did what we use people now practicing called bland embolization, so non-chemo embolization. And see this is after a couple of weeks, you can see the tumor is still significantly vascular. Of course the bleeding stopped, but the tumor is still significantly vascular. So then we did the bland taste with the DE beads, and you can see here significant tumor necrosis with only residual around 30% of the tumor still remaining. So we did another session of taste, and you can see the last CT image. It's completely necrotic tumor. A year later, the patient developed another cancer, and that's what we always look into. She developed another cancer in the abdomen. Also, we treated that with another session of taste and RFA. And you can see there, 2 years almost after, there's complete lack of necrosis. I think the last topic I'm going to talk about is radioembolization. It's been called selective internal radiation therapy. So you deliver the radioembolizing material, which is yttrium, inside the tumor. That will emit some beta radiation to kill the tumor from in out, rather than using the external beam radiation. This is the theory how it was started. If you inject radioembolization in the main hepatic artery, in a normal liver, it's going to go to the entire liver and kill it. But if there is HCC or in hypervascular tumor, 90% or more, it goes to the tumor. Just so we do, it's not like taste. We do very selective, only the tumor. But this is, they can just inject it in the common hepatic artery. So it's provincially all the radioembolizing material here. So it's not embolization, it's just only the material will be carried out through a porters into the tumor, and then this radiation just slowly kills the tumor. Two types in the world are available, thyrospheres and serospheres. And it depends on the component, with some is glass and some other resins, lots of studies about this and that. But thyrospheres are becoming much more popular. it has a much less size of particles and numbers, and that's why the risk even of occluding the vessels with this is almost significantly less compared to the serous fluids. This is an example of a patient. It's a pre-treatment. You can see the injection of the catheter, microcatheter to the left hepatic artery. That's the tumor on the left side. And just post-treatment, you can just see all the vessels remain to be all opacified and only the tumor died. It's not like this. This will be block arteries. You mentioned this. It's an example of a tumor that can shrink gradually over time. So again, they will be bigger at the beginning and then gradually over time they will shrink. I think the beauty of this radioembolization is not for the cases that we use days, because extremely expensive. The one dose, it costs about 10,000 Canadian dollars actually, because it's a Canadian company. It's very expensive, so one dose, one station. But the beauty of it, if these kind of patients, they could be young patients not fit for transplant, not fit for anything, and they have a portal vein occlusion. You can see now a significant improvement and decrease in the tumor burden, because we don't block the vessels here with radioembolization. Again, many articles have already been published about use of radioembolization. It's been estimated 50% of tumor volume will reduce in almost 1/4 of those patients. And the radiation toxicity to liver is not significant, although it can happen in some kind of percentage of patients, around 16%. And this study showed that they did treated 71 HCC patients. None of them had grade 3 or 4 toxicity. And in another study where they treated 43 patients, and the dose was again did not cause any significant liver damage. The good thing about it overall, radioembolization is good when there is a portal vein thrombosis, and it's now being performed mostly as an outpatient procedure, like a day procedure, not like TASER, we have to admit them for 2 to 3 days. I think my conclusion, Mr. Chairman and dear colleagues, that HCC treatment requires multidisciplinary and multimodality approach. Surgical resection and liver transplant, and we're going to hear in the next lecture, is going to be, it's still the better outcome, but it's limited for a specific group. Minimally invasive treatment can be successful for converting patients with unresectable disease into surgical candidates, and can stabilize disease as patients await liver transplant. An RF ablation is the best non-surgical option for small lesions, and even though there are some reported studies showing could be performed for resectable patients and have good similar results. We know now it's combination therapy. Modality-wise, in minimally invasive treatment using TACE and RFA are having much better outcome than using one or the other. And not only that, combination multidisciplinary therapies, TACE, sorafenib may prolong survival, median survival in patients with advanced cancer. I just want to conclude, I would like to invite everybody. We are conducting a conference in King Faisal, and we're going to talk about chest body imaging and breast, and all significant part of it is oncology-related imaging. And there are pioneer speakers from around the world coming and talk about it, so you're welcome to attend that. Thank you very much.
I know everyone is looking forward for that lunch. One more lecture. We would allow for one question if anyone would have. Dr. Ashur, as you mentioned, the size is the biggest limitation for RFA ablation. The bigger the tumor, the less response or the less necrosis for RFA. I want to ask you about this new modality coming and if you would really recommend it or you have any experience with it, which is the microwave ablation. I used to do it when I was training in open surgery, so I'm not sure what's your input on that.
Yeah, microwave now, it started again maybe around 2003 or 4, they started using microwave. Then it started to vanish because the RF really competed all other heating kind of thermal ablative therapies. But recently, in the last probably 3 years now, laser technology has a little bit evolved.
Yes.
And the claim, I don't have an experience with it, the claim is that it will also help to debug the tumor. So it has the potential, but until now there are no studies showing that any other therapy modalities are better than radiofrequency. And everybody is now comparing anything to the radiofrequency radiation.
Do we have any question from the crowd? All right. For this, I would like to thank Dr. Ashur for his lecture, and we'll move on to the next lecture. The last lecture of this session is by Dr. Abdullah Hussawi. He's a colleague of mine. Dr. Abdullah is a new addition to the surgical department in King Abdulaziz University. He's a graduate of this university. He did his postgraduate training in Dalhousie University, Canada, and then went to do a multi-organ transplant and HPV fellowship in Mount Sinai Medical Center in New York. Abdullah is a very dynamic surgeon, academic surgeon who is involved in resident education. He's currently the general surgery program director. He's also big on health advocacy and patient safety. The podium is yours, Abdullah.
Thank you, Mr. Chairman. I would like to thank Professor Mahmoud Shaheen and Tushadi Khayat for inviting me to speak. So just have a look at this slide here where the liver is, and see that this tumor is supplied by the hepatic artery. So this has a significance. I'll come to that later on. So I'm going to switch gears and talk about the fun part. So you guys can wake up just before lunch. The fun because A is liver surgery, and B, we're talking about cure here. We're not talking about gloom and doom and just trying to buy a few months. So here's a question. A 50-year-old gentleman presents with hepatitis B and child A who has 3.5 centimeter right lobe HCC. So having listened to all these lectures, what's the best treatment option? Is it TACE? Is it RFA? Is it Nexavar, transplant, or resection? So we'll come to that. I'm going to talk about specifically some basics of liver surgery and then discuss in some details liver resection and transplantation. And I'll finish off with discussing some controversial issues. So I'm not going to spend much time talking about the incidence here. Again, hepatocellular carcinoma is getting more. We're seeing more and more HCCs. They cause about 500,000 deaths per year. Transplantation and resection are one of the few modalities that can cure these patients. But again, as you can see, that less than 20% of those patients are surgical candidates. Again, this is just okay. This is just to show the incidence. So I'm going to just go quickly through that. So the diagnostic criteria that Dr. Shalak mentioned. I just want to show here that this MRI, the one on the left-hand side is an early arterial phase, and the one on the right-hand side is a portovenous phase. And as you can see here in segment 6, that there's a hypervascularity in segment 6. So this lesion, which is about between 1 to 2 centimeters. And then in the portovenous phase, you see that it washes out. So just to, looking back to that picture that I showed you earlier, a washout is a misnomer. So maybe you can think of it as a washout looking at it, but what it is that HCCs do not have portovenous blood supply. So in the early arterial phase, because they're very vascular, they enhance. And then in the portovenous phase, because of the lack of portovein supply, they look as they're washing out. Actually, the lesion is just not getting any blood supply in that. So the performance status, just wanted to remind everyone about it, just to go through the BCLC staging system, which everyone discussed. This system is very good because it divides these tumors into early, very early, intermediate, and advanced. resection and transplantation. Recently, there's a growing literature that shows that small HCCs can also be cured by RFA. Those less than 2 centimeters can actually be cured by radiofrequency ablation. So just some basics of liver surgery. One thing that we would like our anesthesiologists to do is to keep the CVP below 5 centimeters. Where does this magic number come from? This study actually compared patients that have CVP higher than 5 centimeters with patients that have CVP below 5 centimeters. And the conclusion was that the blood loss and blood transfusion volumes were significantly higher in the group that had high CVP that was higher than 5 centimeters. Just have a look at this tumor here. This is the right hepatic vein in a schematic presentation. This is the middle hepatic vein. So just imagine that the CVP in the suprahepatic IVC will back pressure on the liver. So when you're going through the liver, you do not want the CVP to be high. That just increases your bleeding, even though that you will do a Pringle maneuver, which I will come to next. This is why one of the tricks that we do, we actually, from the time that the patient is in the holding area, we ask the anesthesiologist to slow down on the IV fluid. We actually ask him even not to give it down the fluid if they can. They just put the hip lock in and stop. I've seen a lot of anesthesiologists getting very enthusiastic, just kind of the way that they used to do business, and this is very crucial. These tricks are very important in liver surgery, so whenever you're going for a liver resection, if you're a resident, keep an eye on the anesthesiologist and do not make them flood the patient with fluid, because you'll pay the price at the end. Pringle maneuver. Again, this is a randomized trial compared patients that had Pringle maneuver, which is including the blood supply to the liver. So as we know, 75% of the blood supply comes from the portal vein and 25% comes from the hepatic artery. So including the blood supply, intermittent occlusion, not more than 15 to 20 minutes, is associated with less bleeding. So I showed you trying to reduce blood loss from inflow and trying to reduce blood flow from outflow. That is very important. This is how liver surgery was just transformed in the last century. People used to die having gone through liver resections. So, liver resection, the operative mortality should be less than 5%. There's some Japanese literature that shows a huge series with mortality less than 1%. The 5-year survival for those with HCC is anywhere between 40 to 50%, and it can be higher. The recurrence rate is a problem, and I'll come to describe, to explain why. Transfusion should be required in less than 10% of the cases. The pre-op assessment here is key. As the speakers before me mentioned, you're dealing with 2 diseases here. You're dealing with cancer, and you're dealing with liver cirrhosis. So the extent of HCC, the staging system is important. The liver function is important. The child and the MELD score, the portal pressure should be less than 10. The patient should not have any salivary varices. The platelets should be higher than 100,000, and the patient should not have any splenomegaly. So how do we measure the portal pressure? Again, this is an invasive way of measuring the portal pressure. Now, there's FibroScan, which is non-invasive, but every now and then, patients with cirrhosis that with HCC require to have either TIPS or require to have biopsy, because actually the extent of cirrhosis and fibrosis have an impact on their prognosis. So if the patient is going to go for a biopsy, you might as well just kill 2 birds with 1 stone and try to get actually accurate measurements. So how do they do the measurement? You see here that the probe is going through the right hepatic vein. So suprahepatic IVC, right hepatic vein. This is a magnified picture. So this is a venule from the hepatic vein, and this is the branch of the portal vein. When the tip of the balloon is deflated, you actually get the free hepatic vein pressure. When the tip is occluded, it's like you're doing wedge pressure for PA pressure that the intensivist use. So So that will give you indirect measurement of this segment here, which is directly connected to the portal vein branch. Again, that's another case here. So the HVPG, that's the hepatic vein pressure gradient. How do we measure it? So the free hepatic vein flow, pressure is 2 millimeter here. The wedge hepatic vein pressure is 6 millimeter. So the portal vein is or the HVPG is the result of subtracting 6 minus 2. So that's 4 here. Anything more than 5 by definition is portal hypertension. So we're still okay with patients that have portal hypertension as long as the portal pressure is not more than 10. So you should not have any varices, and there should not be any splenomegaly, and the platelets should be at least higher than 100,000. This here, just for a trivia, this is one of the causes of actually false or pseudo-thrombocytopenia. So you see these platelets, there's this condition called platelets clumping, where some medications actually result in this, but the patients, the CBC will show you low platelets, but actually they have normal platelet numbers, just that they're clumping. So the appropriate technique depends on the location of the tumor, the degree of cirrhosis, and experience of the surgeon. The principles, and these are very important in neurosurgery. You want to minimize blood loss, you want to preserve as much liver as possible, and you want to get an R0 resection, which is the same in any cancer surgery. So one of the most common post-op morbidity and complications are biliary and pleural effusion. It's mainly the right side, sort of a sympathetic effusion. The post-op mortality in most of these cases are due to post-operative liver failure. Again, going back to the point that you have liver cirrhosis and you have HCC, so these patients actually die from liver failure. Less than 10% are due to complications from bleeding. So the presence of cirrhosis is the most important predictor of post-resection liver failure and death. Moving on to liver transplantation, again, this is one of the most beautiful surgeries that you'll ever do. And again, it helps patients, it helps cure HCCs. Starzl is the father of liver transplantation. Back in 1967, the first liver transplant for HCC was performed on a 19-month-old girl. In the 1980s, people started getting interested in doing liver transplantation for HCCs, but the results were poor. And I'll come to explain why. Again, liver transplant addresses both the cirrhosis and the HCC. Patients on the wait list for liver transplant are at risk of dropping out from the list because they just go with beyond being actually good candidates for transplantation. And this dropout rate is anywhere between 25 to almost 40% in 1 year. So these are the first series of patients that underwent transplant for HCC. And as you can see here on the right-hand side, that the 5-year survival is pretty poor. And most of the reasons for this is the fact that these tumors were large and they were multiple. And then in 1996, the landmark study came out from the New England Journal of Medicine by Mazzaferro, where he described the very famous now Milan criteria in liver transplant work. So there were only 48 patients, and this is again, this was not a randomized controlled trial, but it just transformed the treatment of HCC by transplantation. So what are the criteria? You have to have a single tumor less than 5 centimeters, or at least 3, but the diameter should not exceed more than 3 for any one of those. On the left-hand side here, you see that the Mazzaferro landmark trial back in 1996, 75% 4-year survival. And then this is just a personal communication from Mazzaferro, which was published in 2003, and again, very good survival. Well, we get very interested in liver transplantation, so we try to push the envelope. So the UCSF criteria came out, and these criteria were published published by Yale in 2001. So you had to have a solitary tumor less than 6.5 centimeter, or at least not more than 3 nodules with the largest lesion less than 4.5 centimeters. And the total diameter should not be more than 8 centimeters. Comparing both UCSF and Milan criteria, they're very comparable. And again, people got very interested and a plethora of criteria came out. And again, you see that pretty good 5-year survival, as long as you maintain the diameter, the size of the main tumor with less than 7 centimeters. This again explains the y-axis here is the number of nodules, and the x-axis is survival. So the takeout message from this graph is try to minimize the size and minimize the number of nodules to get better survival. Okay, now I'm going to discuss a few controversial issues. So should we use MELD score for pre-op evaluation? And just to remind everyone, MELD depends on the bilirubin, the INR, and the creatinine. It is used in the United States for patients who are on the wait list. And just to link that to the Milan criteria, even if your actual MELD score is low, but you have HCC within the Milan criteria, you get higher points for it. So, because patients with those criteria will benefit from transplant. So again, patients with a MELD score less than 9 centimeters in this study had 0 perioperative mortality after liver resection. What about using portal vein embolization? This is just to show you here a tumor in the right lobe of the liver, but they're very close to the metahepatic vein. So that's a problem now. If you might end up doing a right hepatectomy with excising the metahepatic vein, and this might also go into extended right hepatectomy. Just mind you here that the left lobe is small. So a percutaneous portal vein embolization was done with gel foam, and within 4 weeks, the left lobe, which was 25% of the liver, changed to 40% of the liver. So pretty good indication. If you have someone with cirrhosis, without cirrhosis, the liver remnant, the functional liver remnant should be more than 25%. If less, then you want to think about portal vein embolization. In cirrhotics, you don't want to excise more than 60% of the liver. So portal vein embolization increases resectability, which was proven in different studies. There are caveats here. So as we know that these patients might have bilobar disease. So just you want to be careful that if you think that the other lobe might have an HCC, you just want to take that into consideration, because doing a portal vein embolization it's like with another lobe that has HCC, it's like you're adding fuel to fire, and that HCC will progress very rapidly. And the other thing is the absence of compensatory hypertrophy is actually a good thing for us as surgeons. That tells us that this patient probably should not go for resection. What about anatomic versus non-anatomic? This meta-analysis here, which included 9 randomized trials with more than 1,500 patients, the result showed that there was no statistically significant difference in overall survival. Disease-free survival was greater in the anatomic resection. Local recurrence was not different in either group. So the conclusion, patients with HCC anatomical resection associated with better disease-free survival, but similar overall survival and local recurrence. What about laparoscopy? This meta-analysis here compared studies that looked at laparoscopic liver resection versus open resection. This is the follow-up of the study. There were 15 eligible non-randomized trials, and out of those, 9 high-quality studies were taken out. These are the number of patients in either group. endpoints were operative outcomes, postoperative outcomes, and oncologic outcomes. So for blood loss, laparoscopic resection was better. For blood transfusion, again, it was better with laparoscopy. Post-appendicitis was less with laparoscopy, and hospital stay was less with laparoscopy. So laparoscopic resection is becoming safe, and as long as the surgeon uses the same principle that I showed early on, it's actually very good modality to use, and it's good in kind of peripheral tumors that can be resected laparoscopically easily. What about resection of recurrence? So say that we did the resection for patient and they come back with recurrence. What should we do? As I mentioned earlier, recurrence is a big problem in these patients. 50 to 80% have recurrence in 2 to 5 years, respectively, after resection. There are two types of recurrence. There is the intrahepatic metastases, and there is the metachronous multicentric recurrence. So patients with HPV, for instance, will have just high risk of developing cancer anywhere in their liver. So this schematic presentation here just show you that how patients get intrahepatic metastasis. So they can either get it through local, the black dots here show you the local intrahepatic metastases, whereas the white dots or the circles show you the systemic intrahepatic metastases. So a study comparing repeated liver resection with non-repeat resection showed that repeated resection is associated with better prognosis and no increase in operative mortality in child A. The result was not the same in B or C. So this study concluded that patients with a single recurrence with good liver function are recommended as candidates for a second liver resection. This is another study that looked at resection, second resection versus no resection, and the conclusion was that hepatic functional reserve, tumor number, time to recurrence, and presence or absence of extrahepatic lesions and the type of therapy were independent prognostic factors. The same was shown in this study as well. Vascular invasion is the most important predictive factor of recurrence. So say that you do a liver resection, the pathology shows either microvascular invasion or macrovascular invasion. This is a very high risk factor for recurrence. So you know that these patients are at high risk of recurrence. So I've mentioned the Milan criteria. So what about patients that have bigger size lesions? This study here by Ang showed that actually there's not a bad 5-year survival, which was up to 39% in those patients. Salvage transplantation, what does that mean? It means that you had a patient that had resection, they come back with recurrence. Are they candidates for transplantation? The thinking was that these patients were not candidates for transplantation, but this actually has changed. This study here showed that 135 patients with mean age of 50 years after liver resection who came back with recurrence, 67% of them were actually candidates for transplantation. But this study did not specify the age at the recurrence. The other study had almost 72% of patients that had recurrence and they were candidates for transplantation, but according to that institutional criteria, they didn't do transplant for patients older than 70 years, so the number dropped to 6 from 13. So again, 1/3 for salvage transplantation, that's not a bad deal. So the width of surgical margin, does it contribute to prognosis? A randomized controlled trial here looked at this, and the conclusion from this study was that the prognosis is good with 2 centimeters as compared to 1 centimeter. How many centimeters again was still not fully known. The extent of resection. Segmental resection in this study was found to be superior to non-anatomic or non-segmental resection in terms of survival rate and recurrence-free survival rate. Portal vein invasion or of its branches was the most important prognostic factor in this study. So at least if we're not doing an anatomic kind of lobe resection, you want to take the segment with the portal vein blood supply of it, because the HCC tends to invade portal vein branches. So at least you want to do a segmental resection. Ruptured HCC, the speaker before me, Dr. Asher, showed a case of ruptured HCC. Can we do resections for those? About 10% of patients present with rupture, and clinically they present with acute abdomen, hypotension, and abdominal distension, and drop in hemoglobin. So what is the treatment? The treatment is resuscitation. You want to embolize with or without chemo, and then there's room for diagnostic laparoscopy and or diagnostic laparotomy with resection. This study here was a retrospective study. They had 59 patients with ruptured HCC who underwent surgical exploration. Again, there were no significant difference in disease-free and overall survival between the two groups. And you can see that the overall survival can go up to 48%. That is very good in patients that present with ruptured HCC. People used to think that these patients are not surgical candidates. So I think you want to try to be as aggressive as possible without being unreasonable in these patients. Using neoadjuvant therapy to improve prognosis after resection. The jury here is not out yet. Some studies say they're effective, others are ineffective, so it cannot be recommended at this time. What about the use of adjuvant therapy? Professor Mahmoud asked this question, and interferon was found in different studies, meta-analyses, and others, to be of benefit. There are other things that are being looked at, such as the acyclic retinoid, the PIDO, and tumor vaccines. Sorafenib, again, the question was asked, and there was a trial called the STORM trial. It's a phase 3 randomized double-blinded placebo-controlled trial of using sorafenib versus placebo following potentially curative resection. So the accrual was finished in this study, and hopefully this study will come up with good results, positive results for those patients. So at the end, which is superior, liver resection or transplantation? A lot of studies show that these two modalities are comparable. Again, theoretically, liver transplantation treats both the cirrhosis and HCC. The problem with transplantation is the lack of organs and the immunosuppression. Patients with advanced cirrhosis are good candidates for transplantation. Patients with early liver cirrhosis are good candidates for resection if they meet the resectability criteria. I think this question is not fair. I don't think we should compare these two modalities. I think we should look at it as complementary. One thing that was found in a study by Levet, that a 2-year intention to treat survival fell from 84% to 84 to 54% for 62 days of waiting time, and it fell to 54% after 160 days of waiting time. And it was found in this study that survival benefit of liver transplantation over liver resection disappeared in patients who are on the waiting list after 6 months. So, in other words, if you can't get patients to be transplanted within 6 months, then liver transplant is superior. If you cannot, if they go beyond that, I mentioned earlier that the problem with the dropout rate, I think resection is the answer. So,
Abdullah, we have to close up the session.
so yes, I've got 2 more slides. So the question revisited, so what do we do with this patient? I think it depends, as I said. I think you need to look at the availability of organ donors you have. You need to think of not the fact that yes, liver transplant is good in 5-year survival, but then you need to think of the problems with immune suppression and chronic rejection. So I would try to think of it as try to do resection as much as you can and try to delay the liver transplant while you're thinking that the patient is still a good candidate for transplantation. So to summarize, less than 20% of HCC patients are amenable to surgery. Major resection is not always necessary if you can get an R0 resection. Treatment policy for the policy for recurrent HCC is pretty much the same as first-time HCC. Most of the mortalities come from liver failure. As I mentioned, the margin, if you can get a margin of more than a centimeter, that's good, but if an R0 margin provides that you get the portal vein branches resected is also not bad. The main prognostic factors after hepatectomy are the stage of the cancer, vascular invasion, liver function, and the number of tumors. Portal vein embolization can improve resectability. Benign criteria is the most widely used criteria in liver transplantation, candidate selection, and surgical treatment, either resection or transplantation, is the best treatment for cure in HCC patients. Thank you.
Thank you so much. This is the conclusion of the hepatobiliary session. I'm sure Abdullah and myself will take all the questions at lunch. And I would like to thank the organizing committee of having hepatocellular carcinoma as one of these sessions. And the only message I would give to everyone, this is a very complex malignancy. Having a multidisciplinary approach is the best interest for the patient. Thank you so much.